I want to talk about the different lipid emulsions to be used that we have currently available to be used in the NICU. And my primary goal really is to develop a thinking framework. Sort of what are the steps when you're at the bedside and you're trying to decide what to do, and which of those steps have a good scientific evidence-based approach or evidence behind it. Let's start with, out of curiosity, which IV lipid emulsion do you use as first-line maintenance for preterm infants? I'm going to say preterm infants that are less than 1,500 or less than 32 weeks. A few more responses. Okay. Oh. About half. All right, that gives us a good representation. So here's the framework I want to walk through. The first is thinking about the infant's needs. Second is, what is your therapeutic goal? What are you hoping to accomplish by the use of lipid emulsions? Understanding what the available options are. And then after you know what the available options are, what do you understand regarding the physiology, the biology that they induce? It's interesting, in neonatology, we're taught a lot about understanding what the caffeine does. How does the antibiotic work? What about the vasopressors you're using? What's the physiology as we choose these different medications? I don't hear this discussed when we talk about the lipid emulsion at the bedside. And then once you understand the different biological pathways, what's the risk-benefit of assessing the choice that you have? And then time, absolutely. The concept of time, developmental time especially, is important in your considerations as well. So I'm going to quickly go through each of this and provide you with mainly clinical data. There's a lot of animal databases too, but I tried to stick to the clinical and happy to expound further as you would like. So let's begin with the infant's needs. And Stephanie, you did a great job. I can actually run right through this about just why is nutrition in general important and why is lipids an important consideration as we think about optimizing nutrition. Well, the first one, again, is looking at the infant in front of you. And so on the left, you have an extremely preterm infant. And in our unit, and I think most units still hang on to less than 32 weeks, less than 1,500 grams, you're starting parenteral nutrition. And a part of that is your lipid emulsion. There's some data coming out. Can we feed more aggressively and avoid PN altogether? But I think that data is still pretty early. And on the right, a little older infant, but maybe that infant for some reason cannot establish enteral feeds immediately. And so when do you consider starting nutrition or PN and an intralipid there, a lipid emulsion there? As a general rule, we've been kind of going by, if you don't anticipate being able to get to almost full feeds, full enteral feeds within 3 to 4 days in that full-term infant or near-term infant, then maybe it's a good time to go ahead and start your parenteral nutrition. Meeting energy goals is definitely important, and as we ramp up on enteral feeds, we have to provide something else to be able to meet those energy goals. So to the left is just a demonstration about how with advancing enteral, that lipid background allows you to get closer to your overall total lipid dose. That's important. So you got to think about that as well and augmenting the enteral nutrition that you're providing. There was a discussion about essential fatty acid deficiency. This picture, you won't be able to do that study today. It's actually pictures of the back. I think this was a, 50s study, 1950 something study. Twins randomized to get the essential fatty acids or not. And you see on the right that twin having a nice healthy skin, shiny skin, and the poor twin on the left that was randomized to not get it, starting to show very characteristic signs, the dermatological signs of essential fatty acid deficiency. So we want to avoid that. And then also that was briefly mentioned is the balance of the nutrition and the macronutrients. And one of the best examples I like to share with my team is that we often encounter hyperglycemia in our small babies, but that is reduced. That likelihood is much reduced when you add the other substrates, the protein and the lipid. You're able to come down on your total dextrose delivery while maintaining euglycemia and having less of an impact on high glucose. So lipids are important in all of these processes, but definitely, as mentioned, the energy. We have gotten so good at ramping up our protein, well done protein studies for a very long time. So we are at goal pretty quickly, within a day or two. But there's still a trepidation with lipids, a lot of it historical, but still present in everyone's mind. So it's a little slower when you start and when you advance. And as a result, the energy goals are not met till late. And I love the fact that this was discussed, but in the context of early, because that's what I think is important. Is that what we do within those first 2 weeks matter. It's not, eventually we'll get there. We're talking about nutrition being an important priming effect and really setting the stage. And if we're waiting till after 2 weeks, it is too late. And so here is a series of studies that I like to refer to that emphasizes the energy, but also the early provision. And each of these studies were shy in that early provision of energy, and then looked at their analyses, and they were able to determine that sometimes just an increase of a cal per gram per kilo per day is a 2% reduction in some of the morbidities that we see. And the next one, an increase of 10 kcals per kilo per day with a 5-point increase in MDIs, or your cognitive testing. And then an increase in also of every 10 per kilo of energy, you get better growth and a reduction of BPD and ROP. So we got to think of nutrition as not just calories and growth, but providing important cellular energy and cellular function for organogenesis. So what about the therapeutic goal? So we know we want to start the lipids. What about the therapeutic goal? Well, we talked about some of them already. The essential fatty acid deficiency, growth and energy. And I do believe that whatever you choose as far as a lipid emulsion, we've been able to show that those basic premises are taken care of. I'm not concerned about that as we think about the different options that are coming through. But what I want to stress is to think about, again, nutrition beyond those basics and introduce this element of immunonutrition, where specific nutrients are playing a role on developmental biology and physiology. And here in this summary slide, and you see kind of in the middle there, kind of the most studied immunonutrients, and fatty acids are absolutely in that realm. But how it plays an important in the development of the immune system, the establishment of the human microbiome, but also tissues and organs, wound healing, inflammation, protection against injury. And I added the word organogenesis because that's what we have to think about as neonatologists and pediatricians. A lot of the adult literature and why you can't fully extrapolate is because we already are developed. Our organs are done, and now it's just whatever. Time's going to take the effect on those organs, but we're done developing that. But this is still in process for pediatricians and especially neonatologists, and especially as we continue to push the boundaries of how young we begin to initiate care in the neonatal intensive care unit. So we have to think about the role in organogenesis. I do think that if you look at the studies and older studies that have talked about the maternal to fetal interface and the maternal infant interface, the answers are there for us. We have blueprints in amniotic fluid. We have blueprints in human milk. We have blueprints and studies like this about what is happening during that 21st, 22nd, 23rd, 24th of week gestation that we're caring for these infants. And these are my 3 favorite studies and panels to think about this. The far left really explaining the concept of biomagnification, meaning that what is eventually in the fetus circulation and deposition in the organs actually exceeds that of the mom. And there's very specific placental mechanisms that are selective for specific fatty acids, like DHA and ARA. So the graph on the left really shows that this happens largely sort of at the end of the 2nd, 3rd trimester, where the fetal levels start to outstrip what we see in the mother's levels. These are DHA circulating phospholipid levels across gestational age. In the middle panel, it emphasizes that point when you're able to see what the concentration is in the circulation of the fetus to the mom, and you almost see that it's 2 to 1 for the ARA, almost 2-fold difference, the same around DHA. But if you look at the tissues, this is what I like about this slide, is you begin to understand that ratio in developing fetal tissues. And what do you see there? You see even a arachidonic acid to DHA ratio that's well above 2 to 1, sometimes 3 to 1, maybe even approaching 8, 9 to 1. So I don't think it's a mistake during early fetal development how magnified ARA is relative to DHA. The last panel talks about fetal accretion and where in the tissues that you go, and this small kind of sliver of that line along the hill, that purple and magenta, that's the neurotissue. So it absolutely accretes, as we've learned in brain and eye. But the orange is in the adipose tissue. So as the babies develop, they form these depots, these reservoirs of fatty acids, that stores them and carries them through early infancy after delivery if born full term. But the preterm infant is born well before the development of this adipose tissue, so is immediately reliant on what we deliver at the bedside to maintain any levels that they were seeing in utero that were supposedly supposed to help further promote their organ development. And this fatty acid impact is seen across the board in the literature. We have seen the importance in fatty acids in eye development and the risk of retinopathy of prematurity, in brain development and neurodevelopmental outcomes, in lung development, and in the incidence of bronchopulmonary dysplasia, in immune responsiveness, in the incidence of nosocomial sepsis, and intestinal development, shy of definitive proof yet on necrotizing enterocolitis. So here was the first clinical study that just made me completely excited about this whole concept, because to me, I think this is tangible. This is within our reach to change this at the bedside. And so this is a cohort of about 88 infants born at less than 30 weeks of gestation, where by GC mass spec, we looked at whole blood mole percent levels over time from birth until about a month of age. So on the left panel, and for both graphs, on the y-axis is the mole percent of that fatty acid, on the x-axis is the postnatal week. Since I wasn't sure what's happening in term infants, as a term reference, 10 healthy term infants, probably coming through the NICU for a sepsis evaluation, allowed us to collect some blood for fatty acid analysis as well. And did it at one time point, and that was at time 0, but that was at about term, 40 weeks. So if the preterm baby had remained in utero, that shaded region and that dotted line is where you would expect him to have been. And what we see instead over time for the docosahexaenoic acid, or DHA, the well-known, well-described postnatal acquired deficit of this fatty acid pretty immediately. I have the 1 week mark here, but when we looked at multiple days, it was definitely by day 3, 4, we started to see the fall. And that was true of a recent article, I think by Gibson et al., also describing that this happens pretty rapidly in preterm infants. So that deficit. If you look to the right in the green bars and the green dotted lines, that's the arachidonic acid, so it does the same thing. It comes into this rapid deficit and it stays there. And it stayed there, like once this deficit accrues, it's really hard to recover out of that, even with transitioning to mother's milk and getting them on a full enteral diet. And then linoleic acid almost triples from birth levels. So very quickly, we changed not only the absolute value of these levels, but the relative balance or ratio to one another, completely opposite of what they should have been seeing if they had remained in utero. And it did matter, and I think I'll show you this slide later, but it did matter, those level of changes in the morbidity risk in that study for infants. But just conceptually, this is how I view it. We're that early phase of nutrition to go into this deficit, but now they're in a profile, in a milieu, very different than what they would have been seen in utero, and it does impact all this organ development and organ risk. And then we see later, at 36 weeks and close to discharge, the ramifications of those changes. So what are the available options? If we want to try to address this the best we can and try to approximate what would have been normal or expected developmental trajectories in the face of these fatty acids. Well, there's 3 current options that are available right now. Historically, for a very long time, the intralipid, which is 100% soybean oil. And with the soybean oil content, and you have 20% in the olive oil containing, and then the mixed oil 30%. And what you'll see and why that's relevant is that the sort of amount of soybean, you see there's a corresponding decrease in the linoleic acid content, and then also a corresponding decrease in the phytosterol exposure. The olive oil is only in the olive oil containing. MCT and fish oil are present in the mixed oil emulsion. And with the fish oil, you'll see also higher levels of alpha tocopherol. So those are the differences, very different, one from each other. And so as expected, they do induce very different metabolic responses. There hasn't been yet, as of this time, I don't think, and I've talked about these slides, I should just do it, but anyway, a meta-analysis of the actual levels. So those who know me, that's one of my pet peeves, is sometimes there'll be fatty acid studies out there and they don't get levels, and that drives me nuts because I just don't know how you can conclude what's happening and whether it's even fatty acid based, what you're seeing or not, without those levels. So what I did here is I just took the studies, both prospective cohort and randomized control trials, and I collated them and I said, okay, what did we see kind of consistently in these induced changes in these fatty acid levels? Now, I had to express it as percent change because sometimes folks will look at whole blood, plasma, serum. So our literature is very mixed in methodology, but fairly consistent in sort of what we see as the induced fatty acids. So let's take these one at a time. Let's start in the top row. We talked about the acquired deficit of DHA and ARA, and unfortunately, we haven't been able, at least with a lipid emulsion alone, been able to try to change that early postnatal deficit. The shuttle and the delivery in magnitude that's going across is probably pretty substantial. So it may be really hard to replicate that completely. But all 3 types, you'll go into that initial drop. So let's look at DHA. So the color coding here, so this is percent change from baseline. The blue is mixed oil, blue for fish, ocean. Green is olive oil. And then the orange is the soybean oil. And so for DHA, they go into their deficit, but you will see higher DHA levels using a mixed oil. It tended to be a little further out, levels that were out to 2 weeks of age if they were staying on lipid emulsions rather than earlier, but you do see it. It's there. You see the rise. Arachidonic acid, and this probably surprised me the most, is that, again, they're all through the deficit, but the mixed oil emulsion had a further deficit, or a greater deficit, or an arachidonic acid deficit in accrual than the other lipid emulsions. If you look at the bottom, we talked about the dose gradient of LA. And so, as expected, that's the one thing about fatty acids and these lipid emulsions. You can almost anticipate what these levels would be. So the LA is as anticipated. The soybean oil had the greatest amount of LA, and it had the greatest increase. Mixed oil emulsions were next. They had then the next intermediate decrease and in the overall increase, and then olive oil being the lowest elevation of LA. EPA, and we're going to go through again each of these and the significance of these changes. So EPA is a level that really is low in newborns and stays low, but it is part of fish oil. So unlike the olive oil and the soybean oil that remains kind of on the low side with minimal change, the EPA substantially increases with the use of mixed oil emulsions. And then when you look at the ratio, the mixed oils, because of the higher omega-3 content, has the greatest change and away from a baseline that's noted here on the red horizontal line versus the other two emulsions that seem to maintain what is expected in an ARA to DHA ratio. So now that we understand, and here's a summary table of these changes in fatty acids, now that we understand what happens, where do we want to be along this spectrum to the best, again, of the data that we have? Okay, so what is the clinical impact of each of these fatty acids, and where do we want to aim to be? So linoleic acid, actually one of the few across the spectrum of neonates to adults, you don't want a lot of excess LA. They have metabolites, the H-DOD metabolites. Many of these metabolites have been linked to inflammatory diseases and poor health outcomes. So you want some essential fatty acids. You don't want to be loaded with LA. In that study I showed you, with that one of the first studies about the changes in the postnatal fatty acids, we found that every 1 unit increase in that LA to DHA ratio, so that rise in LA relative to the DHA, had an 8.6-fold increase in chronic lung disease or bronchopulmonary dysplasia. Every 1 unit increase in the LA was a 25% increase in late onset sepsis. And then every 1 unit increase in that LA to DHA ratio there was a 4.5 increase in late onset sepsis. And so the goal here, in my opinion, is to minimize the elevation that you see in LA. And so when you go back to that chart, who's going to accomplish that for you? It's those latter two options of those three options. What about arachidonic acid? This is my favorite topic, and again, full disclosure, because I think this is a misunderstood fatty acid. There's definitely duality to its function. It's a pretty complicated fatty acid, which I think is what makes it fun to study. And so you really have to think about, again, that context of time and where you want to be with the arachidonic acid. But one thing is clear historically is that, again, with the fetal transfer slides that I showed you, early growth outcomes when back in the early 2000s, people were playing with the introduction of these fatty acids into enteral formula. It was shown over and over how it is important for somatic growth. There's been studies and biological studies, animal studies for organogenesis and repair. It actually regulates inflammation, doesn't cause inflammation. So everything we think about in the adult literature for arachidonic acid does not apply to a developing fetus and a developing neonate. And one author called it the essentiality of arachidonic acid during this developmental period. So I implore you not to fear it, but rather embrace it with wide open arms. Here is some clinical data to show the importance of where it fits along that developmental timeline. So this was a study back in the 90s, able to look at, with some autopsy, fatty acid levels. So this was in the cerebral cortex of infants who died of non-neurological causes. That top line is arachidonic acid, the bottom is DHA, and you see very clearly that it's ARA that is the dominant fatty acid, at least in this region of the brain, relative to DHA. And it really, that red line was mine, it really doesn't flip until close to term, about 37 weeks of gestation. So that early organ foundation, arachidonic acid driven. Going back to the prospective study that I discussed, every 1 unit decrease in arachidonic acid was a 40% increase in late onset sepsis. Later studies looking at animal models like zebrafish that amazingly has a more homology to us and our innate immune responses than other animal models showed that the metabolites of arachidonic acid were actually critical in mounting early responses against bacterial infection and bacterial sepsis. So the repletion of arachidonic acid is important. Oh, low ARA. Okay, low ARA linked to ROP in Hellstrom study. So if you want to be in the game of at least trying to preserve it, again, it falls. But if you want to preserve ARA, you're now looking at the previous two. Let's go to DHA. I didn't spend a lot of time on DHA because that's probably the most well-known fatty acid. We're well aware of the benefits. Who at least provides a less of a deficit early and a little bit later, and that would be the third most, the lipid emulsion on that chart. But let's talk about EPA quickly, and then I know people have to start moving along. It's understudied, and it's in the neonate, and it's potentially theoretical, but I think it's real. Think about the way EPA is used in adult populations, reducing platelet aggregation, reducing lipogenesis. Do we want that in a preterm baby who's developing brain and myelin sheaths and everything that completely relies on cholesterols and phospholipids? Here is a study in neonates showing a decrease in lipogenesis with fish oil containing lipid emulsions. Here's an adult study showing a decrease in platelet aggregation with EPA, DHA. Many of these are combined, but I was trying to focus on the potential risk of that rise in EPA. And finally, EPA will shift away from, will prioritize obviously their metabolites and shift away from metabolites driven from arachidonic acid. I just told you why those derivatives are important to maintain. So then, if you're looking at your chart again, who does not, like, where do we minimize that EPA excess? The ratio tends to be a 2-to-1. You want to still maintain an arachidonic acid higher than DHA. On the left is a clinical trial of formulas showing a 2-to-1 being important. And on the right, this is one of my favorite secondary analyses of a trial where they show that DHA did not impact ROP. But when arachidonic acid levels were sufficient, then it did. So we need ARA to lay down that foundation in those structures for DHA to be important. Let me go to the context of time. Risk-benefit, basically, it's about the fatty acid profiles. If you look at meta-analyses, you're not going to see any differences in BPD or sepsis, or at least right now. But we got to think about what we iteratively do when we care for babies in the NICU, where we purposely, everything that we do, we try to write that developmental trajectory in a direction of optimal health. And it's not going to be one change that makes a difference, but a collective package of nutrition. So let me just close with the concept of time, because this is going to be important too. We're all pediatricians and developmental biologists. So hopefully I convinced you with prematurity, we got to maintain this arachidonic acid pool because it's so essential in all of the functions that lead to organogenesis. But at some point, there is going to be a shift of where the dominant profile is over time. Is that late term? Is that term? So do we start to consider our term PN to be very different than what we do from our very preterm infants? And also the context of development and disease. I'm not negating any of the wonderful literature about IFALD and the treatment of it, not the prevention of it, but the treatment of it being really advantageous for Omegavin. But once you have repair, you may have to flip back to growth, and that's back to an N6 profile. So I think most importantly, we got to use physiology for our basis. There's units everywhere that are doing tiny baby units, trying to convince the world that they're unique. Yet, when you ask what they deliver, they're not addressing their unique needs when it comes to maintaining fatty acid profiles essential for growth. So bring that back to your NICUs. Think about physiology, development, and time. Thank you so much.